I'm going to show some cases done in Chittagong. My first case, Mr. SI, 50 years, male, diabetic, hypertensive, history of smoking. ECG shows anteroseptal MI, echo wall motion abnormality is present, and history of anteroseptal MI 2 years back. CAG shows osteoproximal 90 to 95% lesion in LAG. So, guide catheter GL4, guide wire run through F, and balloon, we use several balloons, 2, 3 and 4 size balloon, and we use 2 stand, one distally 2.5 into 30, and another one is 3.5 into 30. Because the lesion to have a significant disparity. So, this is the angio of this patient. Right side have minimum plaque, and in the left side, as you can see, there is osteoproximal lesion in LAG, and also there is a distal lesion. And there is significant mismatch between the proximal and distal lesion. And patient is symptomatic, and then we plan to go ahead for PCI. So, we wear the lesion in LAG, pre-dilate, both distal and proximal lesion. Yeah, it's in a single loop. That's I can just modify it right now. So it will come automatically. So what happened? We took the put a distal lesion 2.5 into 30, and overlapping the proximal lesion, we come across up to ostium of the left main. And the proximal lesion we covered by 3.5 into 38. And we overlap with the proximal stand, and we make sure that there is no, nothing is uncrossed, so that you do not miss the ostium and not to miss the overlapping also. And after doing that, we check in the stand view, and we found that there is some undilated part. We post-dilate the lesion. After post-dilatation, as you can see, there are some pinching of the LCX. So we take another wire, we cross to the proximal start, and we cross the lesion, and then we take a small balloon. We first we dilate the and keep the start enlarged. Then we make a kissing inflation and make a final pot. And as you can see, after making the final pot with the 4 size balloon, the lesion looks healthy. So there is another one. Yeah. This is another case, Mr. AS 57, male, ECG showing LBB. Actually, he had a ICM, ejection fraction 40%, but he has several episodes of unstable angina, and he was admitted with chest pain. That's why we went for angiogram. And while doing angiogram, we found this lesion. As you can see, there is an ugly dissection in the right coronary artery, which is spontaneous coronary artery dissection actually. And there is also spontaneous coronary artery dissection in the LAG and diagonal. As a patient is having chest pain ongoing, and we found only the lesion in the distal LAG could be, we can do something. So we put a small stent in the distal LAG.
2 minutes left.
Yeah. I come with my last case. This is the octogenarian inferior MI patient showing right coronary artery lesion distally, and as you can see, the lesion is very distal and it's a Shepherd screw, and we try to overcome the lesion through regular wire, pre-dilate, and while we try to pre-dilate the lesion, we found that we cannot cross up to the whole lesion length, and we take a body wire to improve the support, but as you can see, the catheter whole thing is coming out while we try to put the forward. Then we take the guidezilla. With the help of guidezilla, we are able to pre-dilate the lesion. We can take the stand in the right place, and also we are able to post-dilate the lesion. And we are able to finish the job nicely. So this is an example where support is matters, and when the traditional matters fail, then we can use the help of Godzilla, we can tackle this type of lesion. So thank you very much for your kind hearing. I have shown some of the few cases done in Chittagong. Thank you.